I'm Dr. Derek Cavatorta.
And I'm Dr. Ashley Taylor. And we're talking this evening about equine lameness.
And we're going to focus in particular about talking about some recent advances in both diagnosis and treatment of lameness in the horse. All right, thanks a lot for coming. I'm Derek Cavatorta, for anybody who doesn't know me. We always put a lot of time and effort into putting these talks together, so it's nice to have a good crowd here. And so tonight we're going to talk about equine lameness, and in particular we're going to focus on some recent advances in the diagnosis and treatment of lameness in horses. Here's just an outline of what we're going to talk about tonight. So first I'm going to start off and just go through some basic definitions to set the groundwork. And then I'll talk specifically about aspects of the lameness exam. And then I'm going to introduce a new piece of equipment that we bought for our practice called the lameness locator that we're really excited about. And then I'm going to briefly go through some diagnostic tests, and then Dr. Taylor is going to take over, and she's going to talk about some treatment options, and then also talk about the role that SRH can play in lameness workups for your horse in the ambulatory general practice setting, and kind of talk about what we can and can't do in that setting. So according to the American College Dictionary, the lameness is defined as being incapable of normal locomotion or any deviation from the normal gait. And in general, this is in response to pain, although not always. So if an animal is experiencing pain in some part of their body, they're going to alter their gait so that they can shift their weight around to help alleviate that pain as much as possible. And that's the type of lameness that we're going to focus on today. Other types of lameness are lamenesses that are a result of a mechanical defect. So we see that with upward fixation of the patella and string halt, where their gait is altered, but it's not because of a painful response. It's because mechanically they can't ambulate normally. And also, you can have a deviation from the normal gait as a result of neurological disease because the nerves aren't firing normally, but it's still not a painful process. And I put this down here for a little bit of relevance and perspective. Lameness is the leading cause of poor performance in horses, and according to a study done by the USDA in 1998, lameness was the most prevalent health problem amongst all horses in the United States. And that seems a little bit striking when you hear it, I think, but if you stop and think about it for a minute, anyone who's been around horses has been around lame horses, and it is very common, unfortunately. So lameness is commonly a sign of pain in the feet and the legs, although not always. Other areas of the body may be affected, especially what we call the axial skeleton associated with the spine. So anywhere from the neck down to the withers, across the back, in the loins, and the sacroiliac region, as well as up near the shoulder and the hip. And it's kind of interesting to think about this. Because of where the center of balance is for a horse, they carry the majority of the weight in their forelimbs. About 60% of their body weight is in their forelimbs. So if you just think about that for a minute, if you have a 1,000-pound horse, they're carrying 600 pounds in their forelimbs, so 300 pounds in each leg, and their legs are pretty small. We have a preparation of a leg here, and these bones are pretty small considering how much weight they're carrying. And that's when a horse is just standing still in its stall, not moving. When they're galloping and jumping, they're increasing the amount of weight on each leg dramatically. And especially at the gallop and canter, there's a moment at each gait where only one single leg is on the ground at that given instant. So the stress loads on these limbs are significant. And when there's a person on the horse's back, the forelimbs, the percentage of the weight of both horse and rider on the forelimbs increases to about 70% because of how it's shifting the center of balance. So because more weight is landing on the forelimbs, it's not surprising that most lameness in horses occurs in the forelimbs. And it's also interesting if you just consider forelimb lamenesses, the vast majority of those lamenesses, probably around 95%, occur distal to the knee. So if we just go back here, most lameness in the horse is in the forelimbs, and of those lamenesses in the forelimb, a lot of them are right down here.
Excuse me. What's that cranial shift and center of balance mean?
That just means when there's a person on their back, the center of balance, the weight is shifted forward.
Oh, okay. Next.
This is a direct quote from Dr. Sue Dyson, who wrote the textbook on lameness. She says, "In my experience, many horses considered to have hind limb lameness by a rider actually are lame in front. Similarly, lameness is perceived as high up, like in the upper hind limb, the pelvis, or the back. In most horses, originates from the lower part of the hind limb." So that's just kind of something to bear in mind. It's very common for us to get to a lameness appointment, and the owner will think that the pain is coming from the hip or the stifle, and it might be the front leg. So, but not always. So these are the essential components of a lameness examination, and I'm just going to talk about each of these in more detail individually. The first is always to get a good history, because the history of the lameness can help you clue in to what's going on with the horse, in some cases before you even see the animal or touch the animal. So the age of the horse is important. If it's a very young animal, you're going to worry more about developmental diseases or joint sepsis, whereas in an older animal, you'll worry more about degenerative diseases or chronic overuse injuries. Different breeds of horse are prone to developing different types of lameness issues, and the use of the horse can affect where they develop lameness. So for example, really high-end dressage horses doing a lot of lateral work often have upper suspensory ligament injuries. Show jumping horses will often have hock pain, and race horses much more frequently develop lameness in the front legs compared to the hind legs. If the lameness has been going on for several months or several days, that can make a difference in how you approach the rest of your exam. And also, if they warm into or out of the lameness, that can give you a little bit of useful information. Also, in general, if they, as they're warming up and moving around, the lameness is getting worse, that's often a soft tissue problem. Whereas if they kind of come out of their stall kind of sore, and as they move around, they get more and more comfortable, that's more typical of like an arthritis type of injury. And then if there are any recent changes in shoeing or training intensity, that's also very relevant. So for example, if the farrier was there 3 days before, the horse came up lame a couple days later, and it's a progressive lameness with pulse in the foot, you might think about an abscess. And that's what this horse had here. I just took a couple swipes with my knife on this horse, and the abscess burst open right here, and that's the abscess draining out the bottom of the foot. And it's always a good idea to just note the conformation of the horse. If a horse has poor conformation, it's going to put strain on different parts of their anatomy that are going to make them prone to certain injuries. So if the horse is back at the knee and their knee is pulled back here, that puts excess strain on the bones in the carpus, and they're prone to carpal chip fractures. If they're excessively straight behind or really post-legged, they're prone to some suspensory problems and also upward fixation of the patella. And if they're sickle hocked, it puts a lot of strain on the area around the hock as well. And then we'll always do a thorough palpation of the horse, looking for areas of swelling, and that can be bony swelling or soft tissue swelling. Areas of effusion, like increased fluid in the joints or the tendon sheaths or the bursas. Heat and pulse are indications of inflammation. Sometimes if a lameness has been going on for a long time, you'll see some muscle atrophy on the affected limb. And so one side of their hip will be less muscle than the other side, for example. And then we'll always use hoof testers to pinch the different parts of their hoof and look for areas of pain there too. And probably the most important part of the lameness exam is to watch the horse go. And we'll generally watch the horse go in a straight line when they're being trotted, usually by our technicians. And I threw this picture in here for their sake because it's been a pretty brutal winter this year. And it's really nice when you guys have indoors, so you should just all get indoors for us to do our lameness exams. And then we'll watch them on the lunge in both directions, and sometimes under saddle, and we'll generally watch them at the walk and the trot being the two most important gaits, and then sometimes also the canter. And we'll observe them on both firm footing and soft footing, and that can give you a little bit of a clue sometimes too. If they're more sore on really hard surfaces, that can indicate pain in the feet and also kind of bony injury. And if it's worse on soft footing, it's usually more of a soft tissue type of injury. And so what are we looking for when we're watching these horses go? I have a big collection of veterinary textbooks, and I have some really old ones. And this is from a textbook from 1903 by Dr. Leotard, one of the earliest veterinarians in the country. And this is what he said. Watching him as he approaches, as he passes by, and as he recedes, him being the horse, the observer should carefully study that important action which we have spoken of as the dropping of the body upon one extremity or the other. And this can readily be detected by attending closely to the motions of the head and of the hip. So if you think about it, if I were sore on my right leg as I walked, I would throw my weight off my good leg and then catch it with my good leg. So I'd throw my body up and catch it on my good leg on the other side. And horses do the same thing, they just have 4 legs. So I'll talk about that a little bit more in detail. But basically they're shifting their weight around to get the weight off the leg that hurts. It's not really that complicated. So in doing that, they'll generally shorten their stride on the affected leg, so they won't bring it as far forward, so they spend less time with that leg on the ground. They sometimes will place the foot irregularly. They should place the foot nice and square, but sometimes they'll land on one inside or outside of the foot or the toe irregularly, depending on where the pain is coming from. They may have an irregular limb flight, so they should bring their limbs forward and backwards nice and straight, but they may paddle their leg out one way or another or drag their toe. Especially if they have soreness in their neck or back, they may just kind of move. They may just move with some stiffness. And then here's the big one: the weight shifting. So for a forelimb, the best way for them to get weight off of their painful leg is to throw their head up and down. And the little mnemonic to remember this is down equals sound. So if they have a left front limb lameness, when their left front leg is on the ground, they're going to throw their head up in the air to get the weight off of it. And when their right leg is on the ground, their head's going to drop down. The same thing occurs on the hind limb. If the left hind limb is lame, their hips are going to be elevated when that leg is on the ground, and they're going to sink when this leg is on the ground. There's going to be a quiz on this, so you pay attention. And then we'll generally grade how severe the lameness is on this scale developed by the American Association of Equine Practitioners. It's a 5-point scale. Grade 0 is sound, no lameness. Grade 1 is an inconsistent lameness that's very difficult to observe, but is there at least some of the time. Grade 2 is a consistent lameness that's only present under certain circumstances, like when they're carrying weight or they're on a hard surface or they're circling. Grade 3 is a lameness that's consistent at the trot under all circumstances, so you can't make it go away when they're trotting. Grade 4 lameness is so bad that it's obvious at the walk, and a grade 5 lameness is basically bearing no weight on the leg. All right, so I have a couple videos of lame horses, and you guys can feel free to shout out your guesses about what leg they're lame on. Because I'm on the spot, so you guys can be put on the spot too. And I've turned off the sound and I've hidden the title of the video so you can't cheat. Yeah, I heard someone say it's a front. It's a front leg. All right, so why do you say? Yep.
Right front, down equals sound.
Down equals sound, yep. So the head, if you watch the head, it's down, down, down. It's down when the left leg is on the ground, so it's a right front lameness. And that's probably a grade 3. So that was a moderate right front limb lameness, like you guys said, and the horse had a distinct head nod. The head and the neck were elevated when the right front was on the ground, lowered when the left front is on the ground. Down equals sound, so it's a right front lameness. All right.
That was moderate,
Yeah.
and I thought that was nasty.
Okay, moderate to severe. Well, we actually can't grade that because we didn't see the horse at a walk.
Oh.
It may not have been evident at the walk, and that would make it a grade 3. If it was evident at the walk, grade 4. So we have one more.
The right side again.
Left
Oh,
arm.
yeah.
I'm hearing left and right, and that's typical. Left hind limb lamenesses are without a doubt more difficult to see. But this is the left hind. It's going to slow down in a second. The hip's going down, down, down. It's going down with the right side, so it's a left hind lameness. And there's some other interesting things. You can see this right hind fetlock drops a lot more than the left hind does. The white one stays nice and upright, and the right one's dropping way down. And the horse also isn't bringing that the left hind is far forward, so it's got that shortened cranial stride. See how far the left one comes forward compared to the right, and the right fetlock is dropping a lot more. So left hind. So like I said, we have left hind lameness with pelvic height. The pelvis was elevated when the left hind was on the ground, drops when the right hind is on the ground. Down equals down, it's a left hind lameness. There was a shortened cranial phase, it just wasn't reaching forward as much with that leg. And the right hind fetlock was dropping further because more weight was landing on that leg. So lameness exams can be very challenging for a lot of reasons. The lamenesses that we just saw were pretty severe and pretty straightforward, presumably, but it's the subtle ones that will really get you, and those ones can be really, really challenging for a variety of reasons. But one is often they can be perceived by the rider under saddle, but not necessarily observed visually by the veterinarian, which is a constant source of frustration for us and for the owner, and I can understand why. And very often we'll see a mild lameness that's not consistent enough for us to block out. And I'm going to talk about nerve blocks in a minute, but I'm sure most of you have seen that. And for the real subtle lamenesses, the nerve block is of no help in further localizing where the lameness is. So we can see the left front has a really mild lameness, but we can't tell where it's coming from in all cases. And then multiple limb lamenesses can be very confusing. And there's also some subjectivity to lameness exams. So if one vet examines your horse one week and another one examines it the next week, they may not see the same things. If the same vet examines your horse 2 weeks apart, they may not see the same thing. And that's actually been shown experimentally. There's a group that they did this in 2010. So they looked at the repeatability of subjective evaluation of lameness in horses, and they got several very experienced surgeons who were lameness experts, wrote the textbooks on it, everything. They had an average experience of 18 years per veterinarian, and they trotted a whole bunch of lame horses in front of them and asked them to just identify what leg was lame, and they agreed about 3 out of 4 times. And these are people who this is their living. So so they can be very frustrating. And it would be very nice to have some sort of a sensitive, objective measurement of lameness in horses. And so that is why I'm introducing the new technology that we bought. So we just bought this equipment called a lameness locator. It only came out a couple years ago. It was developed by a veterinarian in combination with a bunch of PhD computer software engineers and stuff like that. And it's right over there on the table. It's pretty simple. There's 3 sensors that go on the horse. One that sits right here on its head, one that sits right here on its hip, and one that's on the right front pastern. And this sensor, all this one does is tells the equipment which leg is on the ground at any given time. These 2 sensors measure up and down motion and nothing else. And as you trot the horse, they send a wireless signal to that tablet 200 times per second and tell the equipment how much motion you have in the head and how much motion you have in the hip. And then after the horse goes, it does some calculations, which I know nothing about, and it publishes a graph and shows you all the data, and then it actually gives you a report and says, yes, there's evidence of a left front limb lameness. And I have just a quick video of that.
Can it diagnose multiple lameness?
So it's not perfect with multiple lamenesses, but it will give you some idea about that. And something that I'm not going to talk about today because it's way too confusing is the idea of compensatory lamenesses, where a horse that has a hind leg lameness that's severe enough will often have a little bit of a head nod, and that just blows everything I just told you out of the water. If you look closely at that horse that I showed in the video, it did have a little bit of a head nod, and I'm glad no one said anything about it. And this equipment is good at distinguishing true lameness from compensatory lameness. But it's like anything else, it's not perfect, so it has to be kind of taken into context of the history and the exam and all that kind of stuff. This is our technician, Christy. She's in the back. This is one of Helen's sons, Josh's horses, and so here's the equipment. There's this thing on her head, right there on her back. It's just taped down, and then right there over her pastern. And this is one of our technicians, Emily. That's Josh's wife, Mel. And she has the tablet in her hand, and so it's collecting the data continuously while the horse moves. That's Lady.
Surfaces, like you said, a hard and a soft?
You can, and it actually has a spot for you to fill that information in, so it goes into the permanent file, and yeah, it's pretty cool. So these are the benefits that of the lameness locator. So it's nice. It's unlike us. We'll often, we'll do a nerve block, and we really want it to work because we want to know what's going on, and so that may impair our judgment a little bit when we're determining whether or not it worked. And this is not subject to those tendencies. It's also very sensitive. Any motion above 3 millimeters of the head going up and down is what it considers positive. And like I said, it sends a signal 200 times a second, which is way faster than the human eye can take in that information. I think we can take about 10 times per second. And we can also actually quantify our responses to flexion tests and nerve blocks with this equipment. So a lot of times we'll do a nerve block and say, oh yeah, it looks 50% improved, but kind of just, that's very subjective, and this will actually calculate a percentage. And it is useful for multiple limb lamenesses, although not perfect. Nothing in life is perfect. And so we feel this is really useful for our routine lameness exams, but also for what we term soundness exams. Sometimes people will just want us to watch their horses go because they're getting ready for show season or competition, and they just want to see where they're at and what their baseline is. It's really good for that, and it has obvious usefulness in a pre-purchase exam as well. Okay, so all this work we just talked about, lameness locators, watch them go, all that, is to help figure out what leg the horse is lame on. And if they could just talk, that wouldn't even be necessary. So after that, we have to figure out where in the leg the lameness is coming from. And so I'm just going to go through this really quick, but we could do a whole other hour on this type of stuff. But the one thing we'll do is flexion test. So we'll just flex a certain joint on the leg for 45 seconds or a minute to put strain on that joint, and then watch the horse run after we've strained the joint. And if that joint is the origin of the pain, it will often exacerbate the pain. So here's a horse with a left front, let's say they had a left front lameness. They're flexing the knee to see if that's where the lameness is coming from. And like we said earlier, it probably isn't the knee, it's probably below the knee, right? So, and then we'll do these nerve blocks. So the idea is that, so the horse is lame on this leg because it's sore. If we can use carbocaine, just like your dentist, to make the area of their foot that the pain is originating from numb, then they'll run sound. So we'll start with a block here, a PD block, and block out the back part of the foot. If they go sound, we're done. We know that's where the pain's originating from. If not, we'll do another block up higher and block out everything below the fetlock. If they go sound, we know the pain's in the pastern region or the toe. If the next block is up a low 4-point up here, we'll block out the fetlock and everything beneath. So if they suddenly go sound after this block, you'd be suspicious about the fetlock, and so on. And then once you isolate the region of the leg that's affected, you can go on and take radiographs, and that will give you information about the bones and the joints. And this is us taking an x-ray. We have the digital x-rays now, so instant results. It's really nice. And here are just some examples of some x-rays that don't show up that well, but that's got a nail in the foot. And this horse has a big chip in its fetlock, and there's a bone cyst right here in the stifle of this horse, but it's kind of hard to see. But that only tells you about the bones and the joints. If you want to look more specifically at the tendons and ligaments, then we use ultrasounds for that. And so here's an ultrasound of a horse's leg. The superficial digital flexor tendon is right here. This is a normal one, and this one's got a big hole in it. So there's a big core lesion in the flexor tendon. And we can't do this at SRH. You have to go to referral setting for some of the more advanced stuff like nuclear scintigraphy. This is the horse that we did, so that's a bone scan. And this is a horse that we scanned when I was at Cornell. This is a big gamma camera. And so you inject the horse with a radioactive isotope that's taken up preferentially in inflamed tissue. And then you image them on this camera. And if they have some sort of a inflamed area of bone or soft tissue, it will show up as a bright spot. So this is the normal leg, and there's something going on in that fetlock right there. And they also will have CT and MRI at referral hospitals. We don't have those. I didn't have a good picture of a CT on a horse, but I did a CT scan of a pig when I was in vet school, so, so that's what this is. It's a Vietnamese potbelly pig that had a tooth root infection. And they're small enough so you can fit their whole body in the machine. For horses, you can just fit their head or the distal part of their leg, the bottom part of their leg. And those are really useful for taking really high definition cross sections of their anatomy, especially the inside of the hoof, and to see things that you can't see with ultrasound, for example. And they can also do cool stuff like 3D reconstructions based on those, where you actually get a 3D model that on the screen you can spin it around and flip it over, and it's really cool. All right.
So ideally, we go through this whole process. We try to find where the lameness is. We get a diagnosis of what's causing the lameness, and then this section is basically what are we going to do from here on out to fix it. So the first thing, no matter what is causing the lameness, is going to be pain management. And the mainstay of pain management in horses is non-steroidal anti-inflammatories, or NSAIDs, which most of you are probably very familiar with, especially the first two on the list, which are bute and banamine. The way that NSAIDs work, and I'm just going to go briefly over this, is that they block an enzyme called COX, and there's two kinds, COX-1 and COX-2. And COX-1 is known as the good kind. They help with platelet aggregation and also help with gastrointestinal mucosal integrity, which is the big one that everyone thinks about with ulcers. COX-2 is the bad kind, or the kind that causes inflammation and pain. And bute and banamine basically block both of those, and they're called non-selective COX inhibitors. Equiox and Previcox are both selective, so they only block the bad kind, or the kind that cause inflammation, and they leave this kind, which are the ones that are protective for the GI tract, platelet aggregation, and renal function. And I'll go over these a little bit more on the next page. So here I have them. So bute, like I said, is the most common NSAID that we prescribe, especially for musculoskeletal pain. It is non-selective, so we're inhibiting both of those enzymes. Banamine can also be used for musculoskeletal pain, very close cousin of bute. However, it is prescribed usually preferentially for abdominal type pain and colic, and once again, also non-selective. The Equiox and Previcox are a little bit newer on the market, and as I was saying, those are selective against only the inflammation type of COX, so that is really good. The Equiox only comes in a paste form, and it's also more expensive, so we do prescribe sometimes Previcox, which is the canine form of the drug, and the same makeup as the Equiox, but that comes in tablet form, so and they're very small. A lot of horses will eat them in their feed, which is great. Ketofen is something that we use a little less often. It's also selective, but only comes in injectable form, which is a lot of the reason why we don't always give it out. It has to be administered IV. And then Surpass, which is a topical NSAID, once again non-selective. And it's labeled for use in arthritis and multiple joints, but we also use it frequently with some decent result in soft tissue injury. So just quick soapbox on NSAIDs. A lot of people think, well, my horse is in pain. If some bute is good, then more must be better. And there's two different kinds of things that we see people do with NSAIDs. One is called stacking, where they're taking two different kinds, say bute and banamine, and combining them and giving them to the horse. And the other is double dosing. So if your horse is supposed to get 2 grams of bute, then we give it 4 instead. And they've done studies on this, and basically both of these things substantially increase the occurrence of NSAID toxicity and don't improve the pain management of the horse. And the big thing that we see with NSAID toxicity are gastric ulcers, right dorsal colitis, which is in that ulcer category. The protein loss and diarrhea are usually secondary to the ulcers and the colitis. And then colic, once again, usually secondary to this whole scenario. And then renal papillary necrosis, so you can end up with kidney damage and failure also. So that was my quick soapbox on that. So just be careful. Listen to how much you're supposed to give of pain meds. So joint anatomy, just a kind of basic outlining of it. And this is a fetlock joint, where we have bone, and then along the bone you're going to have articular cartilage, and then there's a synovial membrane, which makes up the inside of the capsule of the joint, and then you have synovial fluid, which lives inside the joint. So we're going to talk about that kind of particular area there, and it's just going to give us a little bit of a baseline, so when I start talking about drugs, we understand how they're going to help us. So this is just a picture of what normal cartilage should be like. Once again, where's my little pointy? Oh, I got the wrong one. So this is the bone, and then these are chondrocytes, or the cells that make up the cartilage. And then we have these protein fibers, which have glucosamine, which a lot of people know that word. And then you're going to have joint fluid. So glucosamine is part of what makes up cartilage and gives it that flexible nature that helps with impact. And then we have joint fluid, which has some other things in it we're going to talk about. So this is just a picture of abnormal cartilage. So in this case, we'll have less glucosamine, so we won't have as good as a boundary and an impact material, which can cause more pressure on the cartilage and the bone itself. And then also we're going to have poor quality fluid in abnormal cartilage and in inflammation. Okay, so joint injections, a lot of people are familiar with them but don't necessarily know what goes in the joints. And this is similar when we talk about joint injections. It's similar to other synovial structures as far as bursas, like the navicular bursa or tendon sheaths, which can sometimes be injected as well therapeutically. The 3 main things that go into joint injections are a steroid, which is used as anti-inflammatory, hyaluronic acid, which is going to contribute to normal synovia or joint fluid, and then an antibiotic. Generally, amikacin is the most common, but sometimes we use gent. And that's basically because we're taking a needle and we're going through the skin and into an enclosed area. So it's a little bit of a safety to have some antibiotic in there in case a little bit of bacteria or something goes in with the needle. So there are many different kinds of steroids and a few different kinds of intra-articular ones in particular. The 2 that we use the most are Depo-Medrol and Vetilog. The Depo-Medrol is the longest acting, and the problem that we have seen with it is that it has potentially negative effects on the health of the articular cartilage. So for that reason, a lot of times we use it when we inject distal hock joints and the pastern sometimes, because they're low motion joints. And in the hock joints, the distal hock joints, sometimes when they become very arthritic, part of the treatment plan is to try to get them to fuse, because they're so low motion that if they were just part of the leg and didn't have any motion at all, we would not see any soundness or any kind of deficits in the horse's movement. So that's a lot of times what we use the Depo-Medro for. And as I was saying, it's used where anti-inflammatory benefits outweigh the potential for cartilage damage. Vetilog is the other, which we use more in high motion joints. And at lower doses, it's been shown to be less deleterious to the articular cartilage and can be chondroprotective. And it has a little bit of a moderate duration of action, so it doesn't last as long, isn't as potent as a Depo. Yeah.
So does the methylprednisone, whatever you call it?
Yeah.
Does that actually help to fuse the hocks then, to like speed up, potentially speed up?
Yeah, that's part of it. It can help potentially speed up. Not as much as some of the other therapies that they talk about, like when they inject alcohol or something corrosive to the cartilage in there. And I think that there's a whole thing to be thought of too, as far as not injecting joints sometimes if they're so inflamed that the body's basically going to degrade the joint itself because of the inflammation. It's destroying the normal environment in the joint. So it's not producing normal joint fluid. And then like the picture I showed earlier, we don't have as much glucosamine. They're more banging and rubbing on each other, causing more inflammation. And then you have this cycle. So sometimes injections and calming down that inflammatory reaction are actually potentially better for the joint than just kind of leaving it, especially if you have like a lot of inflammation. So there's a lot of thought that goes into it for sure, but that's why a lot of times we'll use the Depo, because if it is going to negatively affect the cartilage in a joint such as a distal hock joints, we're not going to have a huge issue with that. And if it does speed up the process of fusion, then
So much better.
it's better. Yeah, you got it. So the next component that we put in is hyaluronic acid, and hyaluronic acid is normally produced by the joint membrane, and it's a thick viscous fluid. It helps with lubrication. It helps protect the cartilage from damaging effects of inflammation, and they have seen that it is a little more effective in treating acute joint disease than chronic. The most common type of HA that we use is Legend. That they have another form of HA, High-Visc and Hylartin V, which have a higher molecular weight HA. And basically what that means is there's more HA molecules in the solution than in the Legend. So it's like a thicker, more viscous. So a lot of times that will help us kind of determine what we're going to use as well. High-Visc, because it is so thick, really hard to get into hock joints. So not usually a common choice for that. Other people do use polyglycan. I know if you go out to, ever had your horse out at Tufts, I think they use that frequently to inject joints, and that's a combination of HA and glucosaminoglycans. And that product has been labeled as a post-surgical joint lavage, which basically they made to put into joints if they have an arthroscopy or there's some sort of surgery and they've opened the joint up and kind of, muddled with the normal environment. They're supposed to be able to use that product to put back in the joint so it's more like normal when they close it up. So that's sometimes used as well. Systemic arthrotherapy. So this is a huge market, the oral joint therapies, and I'm sure SmartPack would tell you that big time. So these are just a few of the bajillions that are out there that people ask me about. And there is studies that say that, yeah, they are pretty effective when they're absorbed into the system. So the problem with horses is that they're generally not very proficient at absorbing the molecules that are in them that are helpful. So like the glucosamine, chondroitin are large multi-chained molecules that don't get absorbed very well by the horse. So unfortunately, sometimes it means like a large amount of the product and your investment, because these are not very cheap, can just go out the other end and not be utilized well by the horse. So something to keep in mind when you're purchasing joint supplements. And also many companies I know are continually trying to find a way to make them more absorbable, and we'll see what they do. But They won't tell you this information, I'm sure, when you go to buy them. Injectable joint therapy, so IM and IV. We're basically surpassing the GI tract, so we're getting it straight into the system where we're having those benefits. There's kind of what they term long-term and short-term therapy, but most of these are given on a monthly basis after a loading period. So everyone I know is familiar with Adequan and Legend. Adequan's given intramuscularly, and hence it lasts a little bit longer as it's absorbed into the bloodstream. And it's a polysulfated glucosamine and what that is, it's those little glucosamine molecules that we saw back earlier in the slides that help make up part of the normal cartilage. So we're basically supplying the body with the building blocks that we need for the cartilage. And it's been shown to have a good delay of the onset of joint disease. A lot of people use it, as prevention in sport horses. It does help alleviate symptoms and also prolong the effect of joint injections, people have found. So that is good. Once again, approximate 4-week duration, usually given monthly. The more short-term therapy or Legend is the hyaluronate sodium. So that's the hyaluronic acid. So that's basically giving you part of the fluid that lives in the joint. So this has to do with the cartilage and giving the cartilage building blocks. This has to do with helping the joint fluid be more viscous, better lubricating. So typically this has a greater effect on the joints, but it doesn't last as long. And a lot of times horses that are heavily campaigning, people will do monthly Adequan and Legend, and then 36 to 48 hours before a show, a clinic, something, will give another dose of the IV Legend to maximize the performance of the horse. And that's approximately has a 2-week duration on it. But once again, like I said, usually given monthly. And part of it too is these are very expensive, so it can be cost prohibitive to every 2 weeks Legend, plus every weekend before an event Legend, and then Adequan monthly. So a lot of times you kind of have to sit and look at, this is where we come in, what the horse's problems are, what he's doing for a job, how likely are they to develop some kind of problem, and then come up with a plan from there instead of, going all over the place. Yeah.
2 quick questions. Do you need to use joint injections with Adequan? Like, can Adequan be effective by itself?
Yeah, Adequan can be effective by itself, and basically what they were saying is that if you have a horse that has arthritis and you've given it joint injections, instead of getting the joint injected every 6 months, if you do Adequan monthly for the year, the joint injection may get you another year until you have to have them injected again. Basically, their claim is that the Adequan is giving the cartilage some more support that's helping make the effectiveness of the joint injection last a little longer.
And the other one was, I'm trying to remember if it's one of these meds that is like really hard to get right now, or am I thinking of
It's Adequan.
is that Adequan?
Yeah, they had stopped making it because they had shut down the production for a little bit because of some regulation type things, and then they started again, but because it's such a popular drug, and then everyone I think was crazy ordering it because it was back on the market, so now they're back ordered. So there's a for Lyme's too, the doxycycline. Yeah.
Another one. So
That's another one they stopped making. Yeah, it's a drug regulatory type thing, and there's like politics and FDA and like all kinds of stuff that goes into it that I don't quite understand. But yeah, they're calling us, calling poor Patty, saying, hey, we have this. Oh, we're stopped making this, and constantly, exactly, changing prices. So it does get frustrating, which is why like sometimes we've had to play with some of these other things to try to get products that are similar. Correct, yeah, this is legal. Yep, used for the shows. Polyglycan, like I was talking about earlier, is a combination of HA, chondroitin sulfate, and glucosamine. So a lot of people think it's a combination of Adequan and Legend, but it's a little bit different. It has some of the same building blocks. Once again, this was developed as a post-surgical joint lavage, and people kind of hopped on the same bandwagon and saying like, well, it's really similar to Adequan and Legend, so let's start giving it IV, see if we have the same effects. Some people think, yeah, great, works awesome, works the same. Some say, I don't think it works well at all. And there's no studies to say, you know, whether it's efficacious or not. So, but a good alternative, you know, when things like Adequan go off the market. So we kind of have that on our back burner, and it's good to know about. All right, so a little bit about biologics and regenerative therapy. We have access to all this now, which is great. So IRAP is the first one that I'm going to talk about, which stands for interleukin-1 receptor antagonist protein, long drawn out name. And the big thing is interleukin-1, which is an inflammatory molecule that's in the joint when there's inflammation, and it causes more damage. So basically what this does is it counteracts interleukin-1 in the joint so that it can't cause more damage. And it's kind of confusing how exactly, like chemically, it all works. But we know now that it's easy to basically, all the chemists have figured out how we can manufacture this just from a sample of your own horse's blood. And so what we do is we take a sample of the horse's blood and we incubate it for 24 hours. And it gets incubated in this little syringe with these little glass beads, which the resolution isn't very good on the screen. But the glass beads have a molecule on it that cause the blood to produce this molecule that's going to block interleukin-1, which is the enemy. So we do that, we incubate it overnight, and then after 24 hours, we put it in a centrifuge and we spin it down. And what that basically does is it puts the red and white blood cells at the bottom, and then we can take the serum off at the top, which is where this chemical is that we've developed, that we've had the horse's blood produce. And then we'll just filter it. These little filters that go right on the syringes, and then they'll be filtered, and then it gets put in to the horse's joint. So this has worked really well for horses with synovitis or capsulitis, so inflamed synovial structures, whether it be joints or tendon sheaths. And it does work well to those that don't respond well to conventional anti-inflammatory joint medications, and really good for horses that have had arthroscopic surgery. Because one of the things that steroids do is they decrease the ability for the immune system to function properly. So when you have a joint that you've gone into, you want it to heal. That's the biggest thing after surgery. So we have the capability to put IRAP in there, which acts as an anti-inflammatory without having to put a steroid in there, which is wonderful. And a lot of horses that we've gotten back from surgical facilities, we have IRAP that we've injected their joints with to act as an anti-inflammatory instead of a corticosteroid. Usually do 2 to 3 treatments, and then at 8 to 14 day intervals for it to be most effective. And the good thing that is you just do this once, draw the blood once, and you get 5 to 6 doses, and then you can freeze it. And so then you have not only the treatment, 2 to 3 treatments, but if the horse needs more treatments, or if down the road needs a little more anti-inflammatory help, you have that. Children, something else that is kind of hot on the market, and it's similar to bisphosphonates in humans that we give, and it's basically designed to normalize bone metabolism. Normally in bone, it's constantly remodeling against any kind of stress or pressure that is put on it. And unfortunately, when you get inflammation, sometimes the bone overreacts and will start to pull more bone than it can put down. And then we can see pain and inflammation, which sometimes shows up on radiographs and sometimes doesn't. So what Tildren basically does is it inhibits excessive bone resorption and it promotes rebalancing of bone metabolism. This has been seen most commonly used in horses with navicular disease and hock osteoarthritis. At this point, it's not approved in the US, so it's used off-label. but it's been used in the US for, I don't know, 10 years or so, and a lot of people have had great success with it. And I was talking to one of the reps at a meeting I was recently at, and they're on the lot. They're pretty much getting it approved. It's going to be around shortly, and the price is probably going to go down because it is expensive. But it's definitely a good tool to have. All right, so everything that I just talked about, most common treatments for joint pathology, osteoarthritis. I'm going to get a little bit into soft tissue injuries. So when we say soft tissue injuries, we're referring usually to tendons or ligaments. And tendons, just as a review, connect muscle to bone, and ligaments connect bone to bone. So back to the biologics again, regenerative therapy. So PRP is another thing that we have access to that is a little bit similar to IRAP as far as how we make it. And basically, we know that platelets contain a lot of protein growth factors that help stimulate healing, wound healing. And platelets have been used in all kinds of other wounds, not just in soft tissue injuries, to try to promote healing. And so what the PRP, or platelet-rich plasma, is basically, once again, we're going to take the patient's own blood and we centrifuge it down, and we keep centrifuging it down until we get a high concentration of platelets. And those are just the normal platelets that we have, that live in the blood, and we're, putting them in a formulation and spinning them so that we can basically get them in a syringe. So once we have that, then we can get them in syringes, and in less than an hour can start treating the horse. And this is most commonly used in horses with core lesions, like Derek showed you, the big hole in the tendon. And often we use ultrasound guidance with a needle. So we're looking at the ultrasound, and we find the needle, and we guide right into that hole in the tendon, and then you can inject the PRP, and you can see it go right into that spot. So you're, filling the hole. And like I said, the goal is to drive the repair process and try to help the cells and get everyone active in that area to start healing. And the goal is that we're trying to get the tissue back to its original strength and produce a scarless repair, because scar tissue is not as strong as the original tendon or ligament. As I said, it's usually being used with ultrasound guidance, delivered that way. So this is fairly new, and there are some reports that say, it's wonderful, it's great, the horses, go back to full work and everything is good. And then there's some that say it didn't help at all. So things are kind of a little bit up and down with that. But the one thing that we do know is that there's usually not a lot of risk in doing this kind of treatment, especially because it's derived from the horse's own blood. So they have a lower risk of reaction to it. Except for the fact that it is expensive, so it is a risk for the pocketbook type thing. But for the horse,
What about when you said it's expensive, but what is price range around?
So
IRAP and then this one as well?
I think I'm trying to think of what he was charging for them. I'd have to look up the prices, but it's probably $400 to $500 just to process. And then you have what's expensive, like, sedation, ultrasound guidance, injection, and all, like, everything else that's going to add up with this. And then, it gets expensive because you have recheck exams and all that kind of stuff. But this itself, I think it's, $400 to $500 to get the product. And then, then you're paying for the injection and all that. The next thing I'm going to talk about is stem cells, and that's a lot more expensive. You're in the $1,000 range plus, and that's because of the cost that it takes for the lab to make the stem cells. So, but it's definitely, price is a huge thing that goes into treatment with these things, and some horses are insured, some aren't, some will cover this, some will cover that, and so it's always like a cost benefit analysis when we're deciding to use these products, and how much will it benefit the horse or whatnot. for some horses and some owners and situations, money doesn't matter. So, this is great. And for some, it does. And so then we say, how much benefit and what the goals are of the horse, how old are they, what are they doing, all these things. It becomes a huge, and every horse is different. So we take all those things kind of into consideration, but they're more expensive than basically your other alternative if you have a core lesion and you don't do some sort of regenerative therapy, is to kind of have them sit and do stall rests and put them back on a slow rehab program. So, okay, so stem cell therapy. Once again, these are harvested from your own horse, but they come from the bone marrow or from fat. Bone marrow is preferential and the kind that I've always used. The bone marrow is collected either from the sternum in the horse or the hip. And the sternum is the most easiest. You just inject some local anesthetic and you collect it with a needle. Yeah.
Is that painful?
I don't think it's comfortable, but we usually sedate the horse and put local anesthetic. And then I take a little scalpel and I cut up just through the muscle layers are pretty thin there. And then they have bone marrow needles, which are big open needles that you basically just put up into the sternum and you kind of corkscrew them in a little bit and pull it out. You give them a little bit of Banamine and they're usually, they're okay. I haven't had any that have been like...
And corkscrew explains the end.
Yeah, I mean, you have to like wedge it in there a little bit. But then you get your sample and then you send that. There's Cornell and Davis both have stem cell labs that I've used, and then they have a couple commercial labs also. But basically, we get the sample, we send it to the labs, and then they have to grow the stem cells to get them in a high enough concentration that they're going to have some sort of effect. So they extract them from the marrow, they culture them to expand the numbers, and they recombine them with serum. And then they return it to us for injection. Usually takes about 2 to 3 weeks. Then we take the stem cells and we inject them directly into the tissue. So once again, this is horses that we're talking about with core lesions or holes in the tendons. We use that ultrasound guidance with the needle. So this is kind of hard to see, but here's a core lesion here and here. And this is just supposed to be progression of healing of a horse that they did stem cell with. Once again, they've done lots of studies on this. They were hoping this was going to be like the next best thing in tendon ligament healing and it was going to blow us all out of the water. Unfortunately, it has not been that way. Like I said, it's a little bit similar to PRP where some people have had fabulous results and the horses have gone back to their previous work and done great, and others that have had issues. So we're hoping for less scar tissue, and like I said, more research needs to be done. And basically the difference between this and the PRP is that the stem cells themselves are supposed to be acting as a media to turn into the cells that we want, like the ligament cells or the tendon cells, where the platelets are just basically activating the cells that are already there to heal. So, but like I said, this is, a couple $1,000s to do this, and the others are less expensive. So, the two, usually it's one or the other. I don't see why you couldn't do, the stem cell therapy first, and then possibly the PRP after to try to, get the cells in healing mode. I know it is a little bit time sensitive too, where this works better when you're having some acute inflammation because the cells are already a little more awake, I guess I'll say, than when you're letting them sit. So this is usually something that's done pretty shortly after the horse is injured, and we don't wait 6 months and then go, oh, maybe we'll,
Do they ever inject anything to agitate and cause inflammation to promote it?
There's a lot of that goes on, but it's usually like counter irritants and not actually injected right into the lesion, because I think the other things that we have to irritate tissue are also damaging to the tissue that's already in there. So with these, we have a way to basically, we're using chemicals that the body and enzymes that the body makes itself to try to put it in a high concentration in a directed area to try to stimulate growth and remodeling. So.
Would you do this on younger horses as opposed to, say, a 20 or a 25-year-old horse?
Sure, and I think that's part of the conversation that we'd have, like depending on the case, that it would likely be more beneficial to a younger horse to try to give that young horse, you know, every chance possible to heal the tendon or ligament as strong and as good as we can, especially if it's a young sport horse or, you know, whatnot, compared to an older horse that, you know, is maybe towards the end of their career. Plus, we also have, you know, young horses, just like young people, regenerate and heal a lot quickly than, you know, older horses who don't. And so it may be a little bit more of like, well, this is a 25-year-old horse. We can try stem cell therapy, we can try PRP, but it may be more of a little bit of a risk as far as putting your money in the trash, say, than on a younger horse that you may have a better response with. So I think age, you know, I'd have to do a little more research and if they've looked at that even in the studies, but as far as what I know in my head about, you know, healing and how the body works, you know, I think that you would have better luck with a younger horse than an older horse, for sure, yeah.
The time that you would be off anti-inflammatories before doing this?
No, and you usually give anti-inflammatories during this whole process because we want to balance good inflammation and bad inflammation, if that makes sense. Because, you know, some inflammation is going to help promote healing, but if you have too much, then it's degradative and destructive on the cells. So a lot of times the horses are getting bute or banamine in conjunction with this treatment. So. Okay, shockwave. We also now have access to a shockwave, which a lot of people think, oh geez, like shocking my horse, and that must hurt. And it's actually not electric energy, it's sound energy directed in a focal area. Once again, thought to boost activity and circulation in the area where we're putting the shocks. And the exact mechanism is unknown, but that's the working hypothesis right now. They started using this in people and then started taking what they learned in people to horses, and they found that it's most beneficial for ligaments where it attaches to bone. So suspensory ligament desmitis is in the hind limbs is the most common thing that I've used it for. But they've also used it for superficial digital flexor tendonitis, buctions in race horses, and hock osteoarthritis, which I haven't used it for at all. I know I've used it once in a back case that I had, and it's been beneficial for some horses with back osteoarthritis. So once again, if we're going to increase the circulation, then we're going to increase more oxygen in, and then also the blood is going to take the inflammation out, is what we're hoping. And then they do know that it does have a 48-hour analgesic effect on the treatment area, similar to that of a local anesthetic. And they're starting to make rules now about how close in proximity you can use shockwave to when you show. I think the racing commission in this country you can't shockwave any of the horses like 7 days prior to a race. And I know the FEI, I think, is looking at making rules for a shockwave as well. And I know in Europe they already have rules that you can't use it before they show. Therapeutic ultrasound is another tool that we have access to. Once again, going on using heat and blood flow. And basically what we've always done as far as wrapping and the counter irritation that we're talking about, where we're trying to cause inflammation and heat in the area to try to increase blood flow. The unfortunate thing with that is that usually we're just getting the skin and we're not getting deep. And with the therapeutic ultrasound, we're able to control and get, you know, the deep tissues that we're actually wanting to heal in the leg and heat them up and get the blood flowing there without superheating the skin or having any effect on the skin when it's used properly. So that's really helpful. The heat helps to increase the metabolic activity of the cells. Once again, increasing oxygen and vasodilation, bringing the oxygen in, and then removing waste products and inflammatory mediators. Yeah.
this is probably a really stupid question, but is that anything like what I read about pin firing they used to do?
So pin firing's like a counter irritation type thing where the whole thought, and it's like when you blister a horse, any of those kind of old tracky type things that people talk about, they're having the same thought. Well, if we can, you know, get this area inflamed, we're going to get more blood flow, we're going to bring more oxygen to the area, we're going to get rid of waste. But what we found is that by pin firing, once again, you're doing that, but just at the level of the skin and maybe the sub-Q tissue. You can't really get deep into the tendons and ligaments doing that without causing some really harm if you're really going to go in there and cause damage. And then, I mean, that just destroys the whole point of it. But that's kind of what they were thinking of doing, and it's called counter irritation. But what this is without disturbing the skin at all, we can, using, you know, this machine, we can set it at the level that we want so that we're heating up, you know, the superficial digital flexor tendon or the deep digital flexor tendon, the check ligament, where we want it.
Is that the depth?
Yeah, you do it, and well, you basically do, it's not quite that easy, but it has to do with like the megahertz, so like the frequency of the sound that you do. And this probe and the frequency is different than a diagnostic ultrasound that you see when we ultrasound a horse's leg and we get an image of the tendons. The frequencies are completely different. So by setting the frequency and how often, you know, the sound waves are going, we can determine how deep or how superficial we want them to go. So, and then by the sound waves going in there, kind of shaking everything up, we're getting heat, we're getting, you know, good inflammation, I guess you could say. So.
What's your opinion on magnets as far as, you know, recovering from an injury?
Yeah, magnets are another one of those things that I think some people have seen them be beneficial and some people haven't, and I don't think that it hurts by any means. And I know they have like all kinds of electromagnetic blankets, and they have like magma wave, and they have all kinds of stuff like the force plates. As Derek was saying, there's so much. This topic is so broad. I could do a whole nother thing on that.
I have a little magnet that I put around my horse.
Yeah.
Dispensary, and you don't know.
No, exactly, and it's one of those things like it doesn't hurt.
Right.
So we want to do no harm. But for things like that, you know, the magnetic blankets, people think that they do work. And I don't know that they've necessarily proven that they do, but you can't prove that they don't either, I guess. You know, at least there's no studies.
So
Yeah.
going back to the coastal plan, and with an older horse, if you want to do an overall, you know, just help him with overall arthritis, are you suggesting that it's really kind of a waste of money?
Well, I don't think it's a waste of money because I think they're getting some of that supplement. I just don't think you necessarily, people sometimes put all their eggs in that one basket. So I think they do a lot of hype about the joint supplements and how important they are. And, you know, if you have a sport horse, if you have an old horse, if you have a young horse, like there's a place for joint supplements for every horse. And it's a little bit of a marketing thing, but they don't talk about the digestibility and bioavailability of the drug and what actually makes it to the bloodstream and then what actually makes it to the joint. Yeah, and I think what I usually tell people with not joint injections, with joint supplements is, do you feel like there's a difference or not? And some people say yes, and some people say no. And so if it's, once again, not gonna hurt to feed the horse it may give them a little bit of a boost, but a lot of times I don't think it's of huge benefit, especially in horses that have kind of later stage, more chronic, significant arthritis. I think it's a little bit harder because I think when you're looking at the teeter-totter, I think that the arthritis is probably a little bit more significant than what you're gonna get with like a joint supplement. So.
You mentioned about not wanting to heat the skin. So how damaging are neoprene tendon boots? They heat that leg up.
They do. And they can be, and I've had horses that people have used counter irritation and sweats and have like destroyed the legs and bandage bowed the tendons, and then they end up with the cellulitis, and then they're on antibiotics and.
Because they're, I think, a marketing boost too.
Sure.
They show boots on everything. No
Oh yeah.
You're doing groundwork.
Yeah.
In the yard, they got boots on.
Yeah. And I think the important thing to realize with boots too is that Derek was saying, I mean, like 300 pounds just standing there on the horse's leg. Are you really going to be able to protect, you know, the fetlock from dropping and keep everything in place when they jump over a fence and they land on that one leg? No. I mean, if anything, they help protect them from bumping each other, you know, legs and such, and getting superficial things. But, you know, as far as a lot of the claims that they make for boots, I think those are a little
But the heat
false too.
You feel the heat is definitely not worth it.
Yeah, no, and like I think heat is good in some circumstances, but when you're getting to the point with like counter irritation, especially when you're seeing pathology with the skin, like it's getting like either chemical burns or heat burns from that, then you know, I don't necessarily agree with that, and I think that we have better methods now to try to go around that. All right, we're almost done. You guys are doing awesome. Sorry. Okay, so rehabilitation programs. This, once again, we're going to be looking at the age, injury, disposition of the horse. Some horses will not stand stall rest, so we have to be creative about where we put their stall. If it's under the sky, then sometimes that's where they go. And then progress. So a big piece of the rehabilitation progress and their success is monitoring progress and having serial visits with the vet, having them reevaluate the soundness of the horse. Sometimes that includes imaging, seeing, you know, is that hole filling in or is it not? Because a lot of times we kind of really overlook this piece of it, and it's the most important piece. Especially, you know, sometimes there's little blips along the way. You show up, the horse has been doing great, and then you show up and the horse is lame again. Well, what do? You go backwards, you know, and then you redevelop the rehabilitation program. So it's really individual for each horse. Corrective shoeing, just really briefly, there's a lot of writing on this slide, but the big thing that our goal is to facilitate breakover, normalize the joint angle, equalize joint pressure, reduce joint compression, and maintain normal characteristics of the joint. So the whole thing is that we're taking mechanics and trying to make it as easy as possible for the joint to flex and move and give the joint support. And you know, the same goes with soft tissue injuries. We sometimes do corrective shoeing to try to manipulate movement to protect certain soft tissue structures. So that's, once again, a team effort with your veterinarian and farrier. And just quickly, this is another thing that we have. It's Metron measurements. It's a Metron system where we can actually, this is just a picture of a horse, and we haven't even had to take a radiograph. And the system helps look at the angles of the dorsal hoof wall, the heel angles, the heel height, and basically you can make shoeing recommendations just on a picture of the horse's foot. We can also do this with a radiograph. They have to stand on these special blocks that we have, but we can do it either with a radiograph or with just a picture, which is a little less expensive than taking a radiograph, and really has helped a lot of horses when we're talking about corrective shoeing. So treatment success, cooperation between owner and veterinarian, but horse should be in there because a lot of times they don't cooperate, and that's the confounding factor. So, and like I said, all these treatment modalities that I said, you know, are used in conjunction based on the injury and clinical picture to provide a synergistic effect. We want to try to pick the treatment plan that's going to, you know, fit the horse, the injury, and of course your pocketbook, because money is not unlimited, unfortunately. Prevention, so regular soundness exams, what Derek was talking about, utilizing the lameness locator can be helpful. You know, good quality trimming and shoeing of your horse to make sure that the mechanics are, you know, sound and good to start with, so that they're not leading to, you know, predisposing them to any kind of injury. A good conditioning schedule appropriate for the horse's age, condition, desired sport, and competition level. As, you know, hard as it is not to, you haven't ridden your horse all winter and we get a 50-degree day and let's take him to the beach and gallop. Yes, that sounds awesome, and that's what they do in the movies, but then that's when we get in trouble. So try to avoid that. And then having a good team is key to prevention and treatment of lameness. And just a little why we are on your team. So as Derek was saying, and as you know, hopefully after this presentation, lameness exams can often be a long process and can involve many visits to block and rule out potential causes. Sometimes it doesn't go like that and everybody's happy at the end of the day, so that's great. All lameness exams work all lameness workups start with just the same basic exam that anyone would do when they look at your horse. And most lamenesses don't necessarily require a specialist. I know that's kind of a hot thing now. There's a lot of lameness specialists out there, and they're wonderful, and they do a great job. But don't think that just because your horse is lame, you have to call a specialist, and that it's something that's going to be really hard. Just another thing, we know you, we know your horse, and we know your goals, and we're kind of with you every step of the way, and we want to see you achieve those goals, and we're invested in you. You're part of our family and part of our practice. And so we care about you. And, so we do this whole process, and then sometimes we diagnose a lameness that we, may need treatment that's kind of beyond our training or comfort zone, and, where do we go from there? So consultations is something that we've been doing recently, and we've kind of developed a relationship with Dr. Omar Maher, and I know some of you may know him. He used to work at New England Equine, and he now has his own ambulatory service called Atlantic Equine Services. And he's a boarded surgeon, and he's also boarded in sports medicine rehabilitation. He's quite active in the show horse community. But the great thing about him is that we've kind of developed a partnership with him that has continued to let us be a part of the lameness exam, treatment, and most importantly, the rehabilitation of your horse. So I've had specific cases that have been a little bit, I've diagnosed the horse and say the horse needs neck injections, something that I don't feel 100% comfortable doing on my own yet. So I've had him come in and looked at all the information I've provided, looked at radiographs, absolutely yes, horse needs neck injections. We do them together, and then he says, this is the plan, everybody works together, and then I rehabilitate the horse. And if we have bumps and issues along the way, I check in with him. So it's been super. And the big thing is I think it's really allowed a streamlined diagnostic outcome. And then we've kind of decreased the lack of follow-up and lack of communication that unfortunately happens between specialists and attending veterinarians. And the good thing for you guys is this is all done without leaving your farm, so you don't have to ship somewhere. And sometimes it comes to the point where you do have to ship somewhere because we can't bring an MRI, a CT, and a bone scan to your farm. And sometimes it comes down to the point where you need one, and then we come up with a plan. But I think that this partnership that we have and kind of the goals that we've set are going to really help our clients and their horses.
Is he local?
He's out of Dover, New Hampshire. He drives all over the place, and we've worked with him on a few cases, and he's been great. So that's it.